And welcome back. I'm Mabel, Jong. Thanks for tuning in. We're coming to you live from Washington, D.C. from the World Healthcare Congress 2018. And I'm so pleased to have with me Dr. John Mattison, Chief Medical Information Officer at Kaiser Permanente. Hey there, Dr. Mattison.
Hi.
How are you?
Nice to be here.
Well, you've sponsored or led numerous digital innovations, and you mentor many digital startups. Is that an important space to be in for Kaiser?
I think that the future is incredibly bright and promising in terms of digital healthcare. So it was less than 2 years ago that the president of the AMA declared digital health as a bunch of snake oil salesmen because there have been so many false starts. And the reason for those are many, but a lot of those false starts were related to technologies that weren't quite ready for prime time, that weren't quite fully operationalized in a way that worked for the individual patient or for the individual provider. And what's happening now and what's going to happen in the next 5 years is absolutely going to dwarf what we've seen in the last 5 years, because there's a much greater understanding about how we need to achieve a convergence of multiple technologies into the workflows of the professional and into the lifestyles of the individual person. Mm-hmm. And so the convergence of technology and operations and lifestyle are all coming together in ways that are going to deliver far superior outcomes to what we've seen to date.
Okay, how do we know, or how actually do you know when something is ready for prime time?
Oh, that's a great question, because the rate of change in technology, the rate of change in the business environment, the economics of healthcare, it keeps accelerating. And so knowing when to commit to a particular technology, let alone a particular vendor of that technology, is a really challenging assessment, because the two biggest mistakes that you can make is being too early and being too late. And so knowing when to jump in is really critical. And I think that the most important thing about knowing when to jump in is to have a very, very clear idea of what problem you're solving. Einstein once said, if I had an hour to solve a problem, I'd spend 55 minutes defining the question and 5 minutes creating the answer. And so I think a lot of what has happened to date has been that people have been jumping to solutions before fully understanding the problem. Mm-hmm. And so knowing when to implement a particular technology, knowing which vendor to pick in that space, is something that requires a very clear understanding of what problem you're trying to solve. And let me give a perfect example. So machine learning right now has produced some spectacular results in imaging. And the reason for that is machine learning and the renaissance, this third generation of AI that we're in right now, is enabled by two things. It's enabled by more processing power, and it's enabled by more digital exhaust, the training data set that we need to actually generate useful recommendations out of machine learning. So the time is absolutely right to embrace imaging. However, how do you choose which vendor of the scores of vendors that are doing machine learning on imaging? How do you know which one to bring in for which kind of problem? And coming back to the issue of knowing and defining the problem you're trying to solve first and foremost is critical. So if what you're trying to solve is a radiologist problem of reading an image, that's one type of problem. If you're trying to improve the health of an individual, including their imaging, then you want to get a machine learning imaging vendor who also incorporates data outside of the imaging space, so that the problem that a physician or a nurse or a pharmacist is trying to solve, the healthcare team, is about making life better for a person, not getting the best result out of an image. So the point is, the 2 points. One is machine learning is really ready in the imaging space. In other spaces, it's still very, very nascent. But if you don't work with a vendor that has a vision and a roadmap for how to get to incorporating other heterogeneous data types along with the imaging to render a decision that's relevant to a patient that lives within a larger person that has lots more influences on their health outcomes than just the result of a specific image, then you're ready to make that move. So defining the problem is the most important part of knowing when to go into a particular solution set.
Well, Kaiser has been really blazing trails. I mean, your system was the first to adopt
Sidney Garfield is the Steve Jobs of healthcare, unequivocally. He was the real pioneer around integrated care,
and
integrated systems, all of that.
Records,
all of that.
So when you say that Kaiser is doing this, people listen. What's the next thing that Kaiser has really jumped on?
So we began in the very, very early days of evidence-based medicine, evidence-based practice, and David Eddy and others and I worked on that very intensively in the late 80s and early 90s and ever since. What we're doing now with virtual care and telemedicine and with remote monitoring and with natural language processing and with some of the deep learning opportunities is to look at an evidence-based practice for incorporating all of those data sets into decisions. So we want to look at the whole person. We want to understand what their values and their objectives are. We want to meet them where they live empathically. We want to be able to configure our systems and our data sets and our algorithms so that we address the broader set of issues of what's the highest priority for this person, not just what is their blood sugar or what is their blood pressure, but how do we help them live a healthier lifestyle, and how do we help them better comply with the decisions that they've made about how they want to improve their health. So we're instrumenting our virtual care and our remote monitoring in ways that we can create an evidence-based approach so that we don't have two types of errors. And one type of error is where someone wants to engage in a chat session, and they're a 65-year-old smoker who suffers from diabetes, and they're having crushing chest pain, and they want to have a chat interaction. And the answer is no. The evidence says what we know about your clinical condition. You need to go to the nearest emergency room right now. And conversely, somebody who shows up in the emergency room with a relatively trivial problem, hopefully we can provide them all the service they need without having to travel to the emergency room and consume resources unnecessarily. So we want to adapt the modality of care and the communication modality, whether it's an emergency room visit or a chat session or a video visit or a text or an email. We want to adapt the care modality and the communication modality empathically to what is, on an evidence basis, most appropriate for that person at that moment in time. And so bringing about the instrumentation so that we can actually measure what we do and continuously improve on how we deliver those services for the right person, the right time, and the right modality is a major thrust of what we're doing right now.
Are you using blockchain in your strategies?
We have built a blockchain team and we have looked through quite a few different use cases, and we are beginning to, we've done several prototypes of blockchain use cases, but we don't have any in full production at this moment in time. We have some very, very promising use cases that we believe are going to go to scale nationally. But to be quite honest, because of the partners we're engaging in some of these projects and some of their concerns, I have to play the NDA card about what exactly those use cases are. But we are moving down that pathway.
You are, because it's the filing system, if you will, putting information in ledgers and securing
blockchain is basically a secure distributed ledger. And there are a couple things about blockchain that are not well understood. Blockchain is the best solution for managing secure, chronologically ordered transactions where you do not need a centralized authority. If you can have a centralized authority, that is one authority that manages all the data and all of the flow and everything, then blockchain is probably not the best solution set. The whole design principle behind blockchain is to put trust into the technology so that you can have transactions occurring without either party knowing the other party in a secure, reproducible, immutable fashion. And so the use cases that make a lot of sense, for example, across all industries, not just healthcare, but across all industries, supply chain management, where it's very difficult to get a single centralized authority to manage the whole life cycle of supply chain management, say an automobile manufacturer, whatever. And so what blockchain allows is for these transactions to occur. And Milton Friedman, the Nobel Prize-winning economist, actually described Bitcoin, without using that word, almost 20 years ago today, and characterized how it was inevitable that application of blockchain would occur. The same is true for supply chain management throughout the entire clinical enterprise, but across all verticals, not just healthcare. And so there's something that I call an MVT. So everybody knows what an MVP is, a minimum viable product, which is critical in Silicon Valley. Get something that's good enough, get it out, iterate, and improve it over time. In blockchain, there's this notion of an MVT, or a minimum viable trust. And so the minimum viable trust is, because you're working without a centralized authority, you must have a trust of all the early participants that the solution will work well and be fair to them. And so building a consortium of competitors and collaborators requires a minimum viable trust, and then building out the minimum viable product is actually fairly easy. Building a blockchain application is the easy part. Building the trust to create a decentralized autonomous organization, a DAO as it's called, is what takes time. And so that's what I refer to as the trust paradox. In order to use a technology that obviates trust in individual transactions, you have to invest heavily in building the trust in consortiums before you actually apply that with the technology.
Dr. Mattison, a lot of cool things you get to work with.
Oh, it's a very exciting time, and the most exciting thing to me is the convergence of all the exponential technologies. And so one of the other concepts that I like to think about is, in the convergence of these technologies, what we're really experiencing for the first time in history is what I call a multi-platform ecosystem, contraction, plecosystem. And in this plecosystem, those innovators and entrepreneurs and suppliers of hardware and software and services, those who are best at converging different technologies and converging those technologies with operations and optimization are going to be the big winners. Okay. So the era of single point solutions, particularly in healthcare, is really dwindling very quickly. It's much more about how do you create a plecosystem approach within the plecosystem economy to use multiple platforms, whether it's an API platform or a data platform or a TPU platform or a machine learning platform, how you bring those together in service of people as patients in need.
All right, Dr. Mattison, we're going to have to leave it there, but we'll check in with you in the future. Thank you.
Very well. Thank you very much.
And I'm Mabel Jong. Thanks for watching.